Bernhard, thank you very much. This was a really nice talk. And you have like 1 more minute left.
That's unusual.
Unusual. But please have a seat and enjoy this nice atmosphere here.
Okay, thank you very much, Bernhard. And now I'm pleased to introduce Åsa Petersén. Åsa is a senior consultant in psychiatry and head of the HD clinic at the University Hospital in Lund, in Sweden. She's also a professor of neuroscience at Lund University with a research group focused on understanding the biological mechanism underlying psychiatric symptoms in HD. As you may have seen, she's a candidate for the EC of the EHDN, and we hope to get her elected. So, Åsa, the floor is yours.
Thank you very much for this nice introduction and for inviting me to talk to you here today about understanding emotions and psychiatric aspects of Huntington's disease. So today I'll describe the type of symptoms that are common in Huntington's disease and the reported frequency in the literature. I'll talk about potential underlying mechanisms and how we can understand these symptoms through the stress vulnerability model, the role of sleep problems, as well as direct effect of mutant Huntington. I'll also talk about emotion recognition and emotion regulating neuropeptide system in Huntington's disease, as well as other related neurodegenerative disorders. So psychiatric symptoms in Huntington's disease are multifactorial. Of course, we need to keep in mind that psychiatric symptoms are common in the general population. They can, of course, be a reaction to a difficult situation, living in a family with HD and living with a risk of developing the disease. But also, Huntington's disease affects brain regions important for emotional regulation. The assessment of psychiatric symptoms in Huntington's disease can be complicated by coexisting motor and cognitive symptoms. When looking into the literature, of course, the reported frequency varies depending on assessment tools, disease stages, as well as selection biases, as the people with the most psychiatric symptoms are not likely to take part in observational studies or clinical studies. In order to avoid selection biases and to understand more about the comorbidities of Huntington's disease, including the psychiatric burden in the general population, the following study was conducted. It was led by Hannah Furby and her team members at Roche, together with clinician scientists as myself and Per Svenningsson from the Karolinska Institute. Data was obtained from linked Swedish national registries from 2002 to 2019. That allows analysis of longitudinal data covering the whole nation and the Swedish population. Through personal identification number, this data can be linked from the Swedish National Patient Registry that registers all diagnoses in Sweden in second care facilities and link them to the prescription drug registry as well as the cause of death registry. You cannot leave these registries unless you die or leave the country, so therefore the data is quite robust. In this study, an incident cohort with first diagnosis of Huntington's disease was compared with matched cohort from the general population with HD. So for each individual that was identified with an HD diagnosis during this time, each person was matched with up to 4 controls that were age and sex matched from the general population. That gave us a result of 1,447 people with adult onset HD and compared to 5,772 age and sex matched controls. So before anybody got the HD diagnosis, 11.3 had a history of depression compared to 3% in controls. Here one needs to keep in mind that the diagnoses that were put in the primary care were not included, so this is likely to be an underestimation. What's maybe more true is the history of antidepressants being described, which were up to 38% of the people who would later get an HD diagnosis, compared to 19.3 of controls, really indicating that psychiatric symptoms here, in particular depression and anxiety, are more common before the HD diagnosis. Once somebody had a diagnosis of Huntington's disease, there was a higher incidence of several psychiatric conditions, including acute psychotic episode, which had a 14.5 times higher risk, increased risk of obsessive compulsive disorder, almost 7 times higher risk than for the general population. For depression, almost 6 times higher risk than in the general population, and also 5 times higher risk for anxiety disorders. Furthermore, when looking at the people who were present in the population in 2018, which were, by the way, a little bit over 1,000 people, giving a new prevalence estimation of Sweden from 2018 to be 10.2 people with HD per 100,000 individuals. Here we found that the majority of Huntington's patients, 58 to 76%, had been prescribed antidepressant. And the frequency of people who were prescribed antidepressant also increased after 3 years following diagnosis, really showing how high the psychiatric burden is in HD in a general population. Here as an example in Sweden, but likely to be representative of several other Western European countries. In studies really focusing on the population with HD, many psychiatric symptoms are much more common than in the general population. Depending on which study you look at, you will get different frequency. One of the most early symptoms may be irritability, explained as a very short fuse to a bomb. Other very common psychiatric symptoms are anxiety, depressed mood, which should not be confounded with apathy, which is more of a lack of being able to take initiatives. Suicidal ideation and attempts are also frequent, and I'll come back to that in a second. Altered behavior in the sense of obsessive compulsive behavior are more frequent, as well as persecutive behavior. Here we can see that psychosis is probably more frequent than in the general population, but really not one of the more prominent psychiatric symptoms in individuals with HD gene. Erik van Duyn, who has published many papers looking at psychiatric symptoms in HD, here showed with colleagues the prevalence of different psychiatric symptoms in the registry cohort, showing how frequent they were and how they were also increasing with disease stage. So it's clear that psychiatric symptoms are frequent, but there's not a full penetrance. In psychiatry, stress and the stress vulnerability model, coined by Subin and Spring already in 1977, has been widely used to understand mental disorder and can also be applied to psychiatric symptoms in HD. This model means that at a certain vulnerability and exposed to enough stress, anybody will feel ill. And if you can get under this line, you can feel well. In Huntington's disease, you have the vulnerability of the mutant HD gene. And of course, life is full of a lot of stress. But if you can reduce the stress and get below that line, one can also feel well and maybe not have psychiatric symptoms. And this stress reduction can be obtained by exercise, good sleep, engagement in activities, social interaction, reduced workload, proper and accurate medication, as well as not taking alcohol or drugs. Here, I cannot emphasize the importance of sleep. Good sleep, the correct amount of sleep, is critical for our cognitive function and our capacity to regulate emotions. Unfortunately, sleep problems are very common in Huntington's disease and can also occur early. Clinically, they can be characterized by difficulties to fall asleep, as well as frequent awakenings during the night. Also, alterations of the circadian rhythm have been found. We all know that if we sleep poorly, how easy it is to get irritable, how difficult it is to concentrate, how easy it is to feel anxiety. So clearly, sleep problems in Huntington's disease can really worsen many of the psychiatric and cognitive symptoms in HD. So these are critical and important to treat early, and probably before treating the other psychiatric symptoms. This can be done by improved sleep hygiene, not taking caffeine after noon, reduce screen time in the evening as the blue light is very energizing for the brain, and make sure to have a cool and calm bedroom. Usually it's not enough, and one also needs to take medication to reduce sleep problems. Here are some drugs that can be used to improve sleep in HD and for other conditions as well. For some of them, such as mirtazapine, quetiapine, propiomycin, olanzapine, preferably if there's also presence of chorea or other relevant symptoms, as well as zopiclone, which is one more of a proper sleep drug. Just like it's clear to everybody that the mutant Huntington gene affects important brain regions in control of movement, it's also so that the mutant Huntington affects the brain, affects important brain region for the control of the circadian rhythm, sleep, and emotion regulation. In support of this idea comes many studies using mice. Mice don't normally get Huntington's disease, but one can in a different way insert the mutant Huntington gene into these mice and then compare them to their wild-type litter mates, their sisters and brothers that don't have the mutant Huntington gene, but who have grown up in the same environment. We and many others have found that in several Huntington mice, here I show the back HD mice, that these mice, with the presence of the mutant Huntington gene, compared to their healthy sister and brother mice, growing up in the same cage environment, develop behavioral symptoms. Here I show a classic test for depression, the Purcell-Forth swim test, where the mouse is interpreted of being depressed if it just floats and doesn't want to swim. In the other test, the sucrose preference test, a mouse is thought to be depressed or show anhedonia, the inability to experience pleasure, a core symptom of depression. And you can see that the back HD mice don't care about the sugar water as a sign of depression. And the third test here, a classic anxiety test from mice, the elevated plus maze, where the mouse can choose to be on the open arms to discover a bit the surrounding or hide in the safe corridors. And here again, you can see the back HD mice compared to their healthy sister and brothers show more anxiety. And this also makes mouse model a potential interesting tool to understand more about the neurobiological mechanism of psychiatric symptoms. One of the most serious aspects of psychiatric symptoms in HD concerns suicidality. Death by suicide in the population with HD gene carriers have been reported to be around 5% in different studies. To get some perspective, it's around 1% in the general population, and one can compare it to other severe diseases with psychiatric symptoms, such as bipolar disorder, where there's around 15 to 20% risk and 5% in schizophrenia. Suicidal ideation is much more common. 10 to 30% will at some point have suicide ideas. And so here it's important, I think, in each clinical visit to determine where somebody is in the suicidality stairway, as we call it, when somebody goes from not wanting to live, start to wish to die, get ideas of suicide, make concrete plans, and finally attempt a suicide. There's an increased risk just prior to diagnosis and when independence is threatened. The main risk factors for the HD populations are pretty similar to what it is for the general population. One of the strongest risk factors is a prior suicide attempt, psychiatric comorbidities such as depression and anxiety. Here, the good news is that they are to a large extent treatable. And also other risk factors are alcohol and drugs, which are also things that you can influence and take away. Psychiatric symptoms in Huntington's disease is sometimes called neuropsychiatric symptoms. We call those symptoms also for ADHD, attention deficit hyperactive disorder, as well as for autism spectrum disorder in general in psychiatry. And the resemblance to these symptoms in the HD population can lead to misdiagnosis in non-HD clinics. Here, of course, an important thing is that ADHD has to manifest before 12 years of age, and for autism before 3 years of age. And the reason why there can be this resemblance, in particular, if there's not a known family history for HD, are that there are similar symptoms of dysexecutive function for Huntington's disease and these other diseases. Those include reduced attention and concentration, reduced ability to initiate and organize activity, reduced impulse control, restlessness, hyperactivity, and altered social cognition. One of my favorite images that I often show, cute babies, but also the expression of our basal emotions, the happy, positive emotion, the neutral emotion of surprise, and many of the negative emotions such as anger and sadness and disgust. And there are today now many research studies that have shown that there is a reduced ability to recognize facial expression of negative emotion in HD gene carriers, and that could potentially affect social cognition. Interestingly, however, there are neuropeptides in the brain that are known to be involved in the regulation of emotions and the recognition of emotions. In particular, there are oxytocin, sometimes called the love hormone, and vasopressin, which is correlated to anger. And these are emotion-regulating neuropeptides that are selectively expressed in the hypothalamus. Dr. Sana Scabary, postdoc in the lab, now also an MD, who's here at the meeting, has shown in post-mortem human tissue from individuals who died with Huntington's disease that there are reduced numbers of oxytocin and vasopressin neurons in the hypothalamus in HD. She found a similar reduction in the number of these populations, also in a very rare von Sattel grade 0 case that did not have striatal pathology and had not yet manifested motor symptoms, indicating that this could be an early change. Dr. Rachel Chung, a previous lab member, also gave oxytocin to these back HD mice that I previously showed to you had depression. And by giving oxytocin to these mice, she could reduce their depressive-like behavior, indicating again that oxytocin has something to do with emotional control. Early psychiatric symptoms are not just a feature of Huntington's disease. These are also shared features with other neurodegenerative disorders, where there can be many similarities with Huntington's disease. Two of these diseases are the spectrum of the ALS and FTD spectrum of disorder that are also characterized by the accumulation of proteins inside sensitive neurons, in that case, TDP43. Here, Sofia Berg, a PhD student in the group, just published a review looking at the changes in the oxytocin system, which are now a number of them in HD, and that are also present in ALS and FTD. And I think that's an interesting avenue to proceed, and we're also going to hear more about ALS during this conference. So to summarize, I've been talking about how common the psychiatric symptoms are in HD, much more common than in the general population. They're clearly multifactorial, and we have discussed some ways they can be understood from the stress and vulnerability model, from sleep problems, from changes in emotion-regulating brain circuitries. Good news is that many symptoms can be affected by reducing stress, improving sleep, and the correct medication, and so forth. However, a lot more research is needed to understand the neurobiological mechanisms underlying psychiatric symptoms in HD, and we really need better therapies for many symptoms that we cannot yet target in a good way. Finally, I want to thank my research group, collaborators around the world, funding agencies, and I thank you for your attention.
Thank you so much, Åsa.